Hello, my name is Dr. Ray Chung. I'm Director of Hepatology in the Liver Center and Vice Chief of the GI Division at Massachusetts General Hospital. I'll be speaking to you today about viral hepatitis as we understand it in 2018. In this slide, this is an overview of the hepatitis viruses that are relevant to humans. This is conveniently organized by A, B, C, D, and E. You'll note that hepatitis A and E are bookends of a sort because they describe acute self-limited hepatitis with a fecal-oral transmittable nature and do not in general lead to chronic infection. The exception to that is immunocompromised individuals who can rarely develop a chronic syndrome of hepatitis E infection. Sandwiched between these two bookend viruses are the bloodborne pathogens known as hepatitis B, C, and D infections. They are transmitted either percutaneously or permucosally, and in contrast to A and E, lead and can lead to chronic infection. An important fact is that hepatitis A and hepatitis B are both vaccine-preventable illnesses, and increasingly we are aware of more protective vaccines, although they are not widely available for hepatitis E. There is also post-exposure immunization in the form of immune globulin for both A and B. In contrast, for hepatitis C infection, there is no known vaccine, but we will, of course, discuss the treatments for chronic hepatitis C in greater detail over the course of this talk. Hepatitis D keeps company with hepatitis B. It is a passenger virus, if you will, with hepatitis B, and therefore all measures to prevent and manage hepatitis B in general can help prevent hepatitis D infection. Let's start with hepatitis A virus. Hepatitis A virus is transmitted, as I suggested, through infected food, given its fecal-oral transmission mode, but can also be transmitted through close personal contact. Household contact, even sexual contact, particularly men having sex with men, and daycare centers are a means of transmitting hepatitis A. As well, but rarely, hepatitis A virus has been transmitted through blood exposure, including injection drug use and transfusions. Here's the typical serologic course of hepatitis A. The earliest events after exposure are the shedding of fecal hepatitis A virus. This is followed within the first month by a rise in the ALT and the development of symptoms. This is the earliest serologic event is the appearance of IgM subclass antibody to hepatitis A virus. This eventually wanes and is supplanted by a sustained production of IgG subclass antibody to hepatitis A. You will note here that shedding and infectivity and transmission of the infection occur long before symptoms occur in the index case. This is why, of course, with outbreaks of hepatitis A, there can be transmission, again, long before the first case has been described or come to attention. The mortality of hepatitis A is really related to the age group of the patient affected. So those who are very young tend to have very low case fatality rates. You'll note here that mortality really picks up in those persons in the in their 50s, with a dramatic increase in attributable mortality. Fortunately, hepatitis A virus has an extraordinarily protective vaccine, which is highly immunogenic and highly effective, whether given in one of two FDA-approved versions shown here, the Havrix and the Vactive versions. They're both administered on a 2-dose schedule between 0 and 6 to 12 months, shown here in the dosing formulations indicated in the table. This is an inactivated vaccine. This is not live and can be given to persons even with immunocompromise. It has become universally recommended among children between the ages of 1 to 2 years old, ideally, and is recommended for those who are traveling to hepatitis A virus endemic areas who have sufficient notice, i.e. more than 2 weeks advance notice before travel. Risk groups that I have described earlier should also be vaccinated, as well as those persons with chronic liver disease who are at higher risk for more fulminant versions of hepatitis A with higher mortality rates. So persons with any form of chronic liver disease should undergo hepatitis A vaccination if they're not already immune. There is passive vaccination as well in the form of hepatitis A immune globulin. This can be given to persons who are traveling to intermediate and high endemic regions who have short notice before travel. That is to say, under 2 weeks before notification of travel. So too can it be administered, of course, after exposure to a potential point source. And this typically is maximally effective within 14 days of that exposure. And this can be given to both routine household and other intimate contexts of the index case, as well as selected situations like institutions, daycare centers, where an index case has been described, or common source exposure, such as food prepared by an infected food handler. Let's move on to hepatitis B virus. Hepatitis B virus is a very different virus from hepatitis A, which itself was an RNA virus. Hep B is a partially double-stranded DNA virus whose molecular anatomy is depicted here in this slide. It is a prototype of the hepatna or HepaDNA virus family and encodes 4 major gene products shown here. A non-overlapping, or I should say overlapping open reading frames, pre-S1, S2, and S, which encodes the envelope glycoprotein of the virus, the P cassette, which encodes the HBV polymerase, the pre-core cassette, which encodes the viral capsid protein, as well as the E antigen, and the X protein, which is aptly named because its function is not yet fully described but remains indispensable for the viral life cycle. The pre-core mutation that is commonly described lies here in the pre-core region and leads to a premature termination of an internally encoded E antigen. So E antigen is not secreted in these patients, and these patients consequently are referred to as E antigen negative patients. They can be distinguished as being HBV DNA positive even though they are E antigen negative. That is to say, they are capable of maintaining and continuing replication, albeit at typically lower levels than those persons who are E antigen positive. The next slide depicts the viral life cycle of hepatitis B virus. So Hep B enters the target cell, in this case the hepatocyte, through a cellular receptor, co-receptor, and then is internalized into the cytoplasm. From here, the viral nucleic acid, the HBV DNA, homes directly to the nucleus, where it establishes residence as a highly latent form known as CCC, or covalent closed circular DNA. This is a highly stable form which becomes extraordinarily difficult to eliminate from an infected cell. It is the template for messenger RNA production and transcription. Those mRNAs of varying lengths make their way out into the cytoplasm, where they are translated into a variety of proteins, which I just demonstrated to you in the previous slide. And these proteins then carry out the business of replication by taking that pregenomic RNA, copying it into a complementary DNA strand, which in turn is then copied into a second DNA strand to reformulate the double-stranded DNA genome. Coupled with this is the formation of the virus itself, with the assembly consisting of coupling with the capsid antigen and the surface antigen to generate mature variants which mature through the ER and Golgi apparatus. In parallel, there is excess production, translation of surface antigen, and surface antigen can then be produced essentially as subviral particles, shown here as SAG. So a person can be producing protein but not necessarily replicating, and these persons may have very low or undetectable levels of DNA, yet be surface antigen positive. These persons are called inactive carriers. E antigen is produced and secreted and is, generally speaking, in concert with active HBV DNA replication. So E antigen is thought to be a surrogate for active HBV replication. The risk factors for hepatitis B transmission are indicated here in this pie chart from the CDC. And these risk factors have remained relatively static over time. There is a small portion of persons who transmit Hep B through injection drug use, but the dominant form of transmission is actually sexual transmission, whether heterosexual or men having sex with men. There is still an unknown, a fairly large unknown segment whose causes are not yet identifiable. This is the typical infection course of hepatitis B in a person who experiences a recovery. So following infection, there is appearance of hepatitis B surface antigen as the earliest event. This is accompanied, and again with active replication, by E antigen positivity. With successful engagement of the immune system, there is an appearance of IgM antibody hepatitis B core, which again eventually rises and falls and gives way to IgG subclass anticore, which persists indefinitely. Ultimately, there is neutralizing antibody production in the form of anti-HBs in persons who experience successful spontaneous clearance. This is, again, paralleled by the appearance of anti-hepatitis B-E. Symptoms typically, again, occur early. The incubation period of this virus is somewhere in the neighborhood of 10 weeks on average. One can see here that symptoms occur somewhere about 3 months after inoculation of the infection. It is very important to point out that in diagnosing acute hepatitis B, one should not only look at surface antigen as a measure of acute infection, but as well as the IgM subclass for antibody core. And that is, of course, because there is a seronegative window between the appearance and disappearance of surface antigen and the appearance of anti-HBs. So IgM subclass antibody to hepatitis B core is essential for maximizing the diagnosis of acute hepatitis B infection, of course, in context with abrupt and acute rises in ALT, with or without jaundice. In the person who experiences chronic infection, who's not as fortunate, and this may be up to 10% of adults who are exposed to hepatitis B, there is persistence of hepatitis B surface antigen, again with accompanying persistence of IgG subclass to antibody to hepatitis B core. In these persons, hepatitis B E antigen may persist, and sometimes for months, if not years, and eventually give way to the appearance of anti-HBe to signal the development of a non-replicative stage of infection. The predilection for the development of chronicity is a direct function of the age of exposure of the infected person. So you can see here there is an inverse relationship between age at exposure and the likelihood of infection, so that those exposed at birth or perinatally have an extraordinarily high rate of persistence of hepatitis B infection. In contrast, those exposed as older children and adults almost always clear the infection. Now, not surprisingly, this is accompanied by a higher likelihood of having developed symptomatic infection, in fact, even icteric infection. Again, consistent with the engagement of a potent or robust immune response to the infection. So clearly, the transmission of hepatitis B in the world today is related to vertical or perinatal transmission because of the extraordinarily high rates of persistence and chronicity at that stage of exposure. When we think about those who are chronically infected then, which may be many persons who come from endemic areas who acquired the virus perinatally, this natural history will play itself out over decades, typically 3 to 5 decades. The acute infection gives way to chronic hepatitis, which again can last many years, and in the case of those who have active replication, can progress onward to advanced forms of fibrosis and even cirrhosis. Once cirrhosis has developed, persons may experience further deterioration of liver function in the form of decompensation and death from liver failure, and an independent risk for hepatocellular carcinoma, which can develop not only in persons with cirrhosis, but independently in persons who have lesser forms of hepatitis as a result of integration of hepatitis B into the host genome and insertional mutagenesis. The next slide depicts the stages of chronic hepatitis B infection as we understand them. And this is played out over the course of a lifetime. In this example, those exposed early, fail to engage the immune system, which is, in essence, tolerant of hepatitis B. In this situation, then, there are very high levels of HBV DNA replication, along with E antigen positivity. Because of the lack of engagement of the immune response, the ALT levels are typically normal, with extremely mild or normal histology on liver biopsy. Eventually, this gives way over time, sometimes in the youth of the patient or in the early 20s, to an immune clearance phase in which the immune system is now engaged. It now brings down HBV DNA level, often with ALT elevations, and here we will see histologic abnormalities, sometimes with moderate to severe chronic hepatitis. And unchecked, this may progress even to more advanced forms of fibrosis. These individuals may experience a clearance and movement into a replication silent phase, in which they seroconvert all the way to anti-HBe positivity. HBV DNA levels become very low or undetectable, and ALT levels are normal. This may be called essentially an inactive carrier state. These patients may again revert back to a normal or mild histology or an inactive form of cirrhosis. At some point in time in a subset of patients, particularly those from endemic areas, they may eventually select for a so-called pre-core or core promoter variant, or so-called E antigen negative form of chronic hepatitis, in which replication now becomes resurgent. The HBV DNA levels rise, ALT levels may rise in an accompanying manner, and histology becomes more active. These are persons, again, that we would characterize as having E antigen negative chronic hepatitis. Another way to look at this is to look at the HBV diagnostic tests in order to try to parse between each of these clinical states. So on the far left, we can see that in a person with acute hepatitis B will be surface antigen positive. They will not have developed anti-HBs. They will be E antigen positive, at least early in infection, anti-HBe negative. Their anti-core will be positive, including the IgM subclass for anti-core. And of course, they will have HBV DNA positivity consistent with replication. They will have often marked elevations of ALT to distinguish them as being acute. Those who go on to clearance, spontaneous clearance, will then seroconvert to anti-HBs positivity. They will have lost E antigen and possibly move to anti-HBe positivity. Anti-core persists in the IgG form, but no longer in the IgM form. Their HBV DNA is now undetectable, and they've normalized their liver enzymes. This is to be distinguished from the patient who has never been exposed but received immunization. In this case, they've received the surface antigen as the immunogen, so they will be anti-HBs positive. But to distinguish them from the naturally infected patient who is cleared, they will be anti-core negative because of the lack of core protein in the vaccine. So this is the way to distinguish a naturally immune patient from an immunized patient. So the patient populations we care about who have chronic infection are persons who have surface antigen positivity. They, of course, are anti-HBs negative. The E antigen positive group, of course, has that serologic marker. They're anti-HBe negative, anti-core positive, and will have high levels of HBV DNA replication, often with elevated ALTs, but not always. The E antigen negative patient, again, as the name befits, is E antigen negative and E antibody positive, consistent with the idea that they have formulated E antibodies sometime in the past. Their IgG anti-core is positive, and they will harbor typically lower levels of replication than the E antigen positive group of patients, but will have replication. Again, elevated ALT may occur, but sometimes may not. So it's very important to distinguish this group from those patients who are so-called inactive carriers, who again are surface antigen positive, E antigen negative, anti-HBe positive, anti-core positive, but are distinguished by having essentially undetectable or minimally detectable HBV DNA levels with normal ALT. So if one had a single test to distinguish the important groups of patients, it would be the HBV DNA level. And this is a group of patients that really are important to identify because of their risk for progression and therefore the need for antiviral therapy. And that's indicated really in the next several slides, in which essentially HBV DNA level is predictive of clinical outcome, whether it's the development of cirrhosis or the risk of hepatocellular carcinoma. This classic series of patients, numbering in the tens of thousands, was followed over time, in this case over a dozen years, and their risk for cirrhosis was charted based on entry viral load. And you can see here there is a gradient of risk from lowest viral load to highest viral load for the subsequent development of cirrhosis. So viral load in many ways predicts clinical outcome, untreated clinical outcome in patients with chronic hepatitis B infection. Fortunately, we have an array of FDA-approved options to manage chronic hepatitis B, and they're listed here. They include nucleoside or nucleotide analogs like lamivudine, adefovir, entecavir, tenofovir, tolbivudine, and more recently tenofovir alafenamide. The one outlier here is interferon alpha 2A, which acts as a nonspecific antiviral cytokine. Currently, the standard of care are entecavir or tenofovir, and more recently tenofovir alafenamide, which we'll discuss in a moment. Other approved agents with anti-hepatitis B activity, which are not approved specifically for HBV, are the HIV drug emtricitabine, which is analogous to lamivudine. So what about the clinical data as they relate to these FDA-approved agents? These are data that summarize a series of trials that are not conducted head-to-head, looking at our current standards of care, including entecavir and tenofovir, which were given for 48 to 52 weeks, compared to peg interferon given for 48 weeks. And one can see here, when it comes to e-antigen positive patients and the likelihood of obtaining undetectable HBV DNA, we see that the nucleoside or nucleotide analogs perform very well, 67 to 76% rates of undetectability compared to peg interferon, which delivers about 25% in such patients. Unfortunately, in terms of the more durable endpoints, we appear to get to those less frequently. So e-antigen seroconversion, which could be conceivably a durable endpoint in these patients, is really experienced no better than 20 to 30% of the time, at least in the first year of therapy. Particularly true for the nucleoside and nucleotide analogs, where those numbers are closer to 20%. With extended therapy, we do see some incremental gain in e-antigen seroconversion into the 45 to 50% range by year 4 or 5 of therapy for entecavir and tenofovir, respectively. But we really appear to get not much further than that when it comes to long-term e-antigen seroconversion for this group of patients. So the expectation then is that more times than not, we will not be able to get these patients necessarily to a durable endpoint where we can expect to stop medications. In terms of the most durable endpoint and the holy grail of antiviral therapy, this would be surface antigen loss. This is an extremely infrequent event for whatever treatment is FDA approved. You can see here that in the first year of therapy, we experience really no better than 3% loss of surface antigen. In e-antigen negative patients, who tend to have lower levels of HBV DNA generally than e-antigen positive counterparts, we do better with entecavir, tenofovir, and peg interferon in terms of achieving HBV DNA undetectability at a year of therapy. But so too here, the ultimate, again, goal, that is to say surface antigen loss, is really, again, elusive. So no better than, again, 3 to 4% rates of surface antigen loss at 1 year of treatment. More recently, a prodrug of tenofovir has been developed and approved by the FDA for chronic hepatitis B, and this is called tenofovir alafenamide. As a prodrug, it has much more efficient intracellular uptake into hepatocytes than does tenofovir disoproxyl fumarate, giving it much less systemic exposure than TDF itself. Less than 8% systemic exposure compared to TDF. Phase 3 trials have compared 25 milligrams of so-called TAF to TDF 300 milligrams in both e-antigen positive and e-antigen negative chronic hepatitis B, and have essentially produced non-inferior results, essentially equivalent results in terms of clinical endpoints for both e antigen positive and e antigen negative forms of chronic B. Most importantly, over the long term, there were smaller decreases in bone density and creatinine clearance observed with TAF as compared to to TDF for chronic B. TAF, incidentally, is also approved for HIV, much as TDF is. The good news with the monotherapy of these agents, in contrast to monotherapy to HIV, is that tenofovir and entecavir, shown here on the right, over many years of administration, do not engender genotypic resistance, and so can be given safely to our patients as monotherapy once daily over many years without this concern. In contrast to other nuke analogs, which have produced higher rates of genotypic resistance. Therefore, for chronic hepatitis B, tenofovir and entecavir remain our standards of care. The great news with regard to suppressive antiviral therapy, even though cure remains elusive, is that we can make an extraordinary clinical difference with viral suppression. These are data from a classic study that conducted a number of years ago in East Asia, wherein cirrhotic patients with chronic hepatitis B were administered placebo or lamivudine, which was the treatment of the time as a nuke for chronic B, and evaluated for the subsequent development of either an increase in the Child-Turcotte Bue score, i.e. decompensation, the development of hepatocellular carcinoma, or any of a number of endpoints in a composite that consisted of both CTP elevation, HCC, spontaneous bacterial peritonitis, renal insufficiency, or bleeding varices. The study, which had been planned for 5 years, was terminated early because of the statistically significant emergence of endpoints between the lamivudine group and the placebo group, and has now become the mainstay of therapy for any patient with cirrhotic hepatitis B in terms of preventing these feared clinical complications. Let's move on to consider hepatitis D virus, which should be considered in a package with hepatitis B. Hepatitis D is really not a classical virus. It is actually a defective viral particle, which is a single-strand RNA nucleic acid genome. It's classified as a delta virus related to the viroids or the plant satellite viruses. But the major point here is that it is ultimately dependent on hepatitis B virus itself for assembly, expression, and infection. So this is the HDV RNA genome shrouded by the HDV antigen and ultimately surrounded by the hepatitis B surface antigen itself. So it requires the cloak of HBV surface antigen in order to be infective. So when we think about hepatitis D virus, given this dependence on Hep B, we can think of it essentially as being a co-infection with Hep B, producing severe acute disease, typically associated with a low risk of chronic infection, or alternatively as a superinfection of persons with already established chronic hepatitis B. In this context, these persons usually develop chronic hepatitis delta and have a higher risk for severe progressive chronic liver disease. Of course, as we think about this, there are similar risk factors for delta as there are for hepatitis B, with a number of descriptions of hepatitis delta in outbreaks in injection drug users. So here's a typical co-infection scenario in which hepatitis D and hepatitis B co-infect the liver. There is a very early appearance of IgM subclass anti-delta, eventually replaced by anti-delta of the IgG variety. Surface antigen, of course, appears simultaneously with HDV RNA, and then these are eventually accompanied by both symptoms and ALT elevation, and ultimately, because of the high frequency of clearance of B, antibody to hepatitis B surface antigen. In contrast, superinfection again occurs in somebody who is already surface antigen positive and maybe in a stable phase of that chronic Hep B, then develop a spike with, again, HDV superinfection with the appearance of HDV RNA, IgM anti-delta, again replaced by IgG subclass anti-delta. These persons can get quite sick, The ALTs rise and may then settle into a smoldering chronic pattern, which may be ultimately quite progressive, as I've indicated. Let's move on to hepatitis C virus. Hepatitis C is a very different infection, which is a member of the flavivirus family, whose cousins include West Nile, dengue, yellow fever virus, and more recently Zika virus. It has a very simple genomic organization. It is a single-strand RNA virus of about 9,400 nucleotides that encodes about a 3,000 amino acid protein shown here. This protein is chopped into a number of mature peptides by both host proteases as well as a virally encoded protease to yield 10 mature peptides, the upstream portion of which is concerned with structure of the virus, core and 2 envelope glycoproteins. The downstream portion of which, or the non-structural portion, is concerned with replicating the viral genome itself. These include the NS3 protease, which again chops up the viral polyprotein into smaller parts. The NS5B protein, which is called an RNA-dependent RNA polymerase, which carries out the replication of the viral RNA genome into new RNA strands. There is yet a third protein known as the NS5A protein, which is a replication complex protein that is required for both replication as well as a separate step of assembly in the viral life cycle. These three proteins, the NS3 protease, the NS5B polymerase, and the NS5A replication complex protein, have really formed the intensive focus for small molecule drug development against hepatitis C. In the case of the NS5B polymerase inhibitors, there are both nucleoside or nucleotide inhibitors that act at the active site of the NS5B polymerase, causing premature chain termination of the growing viral RNA chain, and non-nuke inhibitors that induce conformational changes in the NS5B protein, thereby limiting access of nucleotides into that growing RNA chain. The life cycle of hepatitis C virus is actually relatively straightforward, in which hepatitis C enters the hepatocyte through a number of receptors or co-receptors. The viral RNA genome becomes uncoded in the cytoplasm, where it is then translated into the polyprotein I just showed you. That polyprotein takes up residence on altered endoplasmic reticulum membrane to form what's known as the replication complex or the membranous web. It is here that the genomic RNA is copied into a intermediate form known as the negative strand RNA, and in turn back into new genomic RNAs. These RNAs are then packaged with structural proteins, namely the core and envelope glycoproteins, into mature virions, which then exit the cell through exocytosis, only to infect new target cells. You'll notice here that there is no stable intermediate form. There is no DNA intermediate of this viral RNA. And as such, this requires continuous replication for its existence and survival. Thus, because the RNA does not integrate into the genome, this is conceivably a curable infection because of its potential ability to be to have replication extinguished. The other point to make here is that the NS5B polymerase is an error-prone polymerase. That is to say, it makes one nucleotide misincorporation with every replication cycle. Given that 10 to the 12th cycles or 1 trillion cycles are occurring in an infected person daily, there is an extraordinary genetic diversity generated at each of the nucleotide positions. This has led to the description worldwide of extraordinary diversity in the form of at least 6 major genotypes and many subtypes within genotypes, as depicted in this phylogenetic tree. There can be up to a 30% amino acid difference between genotype 1 and genotype 3, for instance, which makes them virtually different viruses. When one looks at the distribution in the U.S., about 3/4 of infections are genotype 1, and the lion's share of the remainder are genotypes 2 and 3. They historically had different rates of response owing to their different structures to interferon-based regimens, 45% in genotype 1 and 80% in genotypes 2 and 3. When we think about risk factors for hepatitis C, again, this is a bloodborne pathogen. The major mode of transmission of hepatitis C is through injection drug use, shown here. Sexual transmission can occur, particularly among MSMs who are already HIV infected, where outbreaks have been described in this group of patients. When we think about the HCV epidemic here in the United States, This was essentially a group that was infected in the 1960s, 1970s, and 1980s, largely as a result of injection drug use, to a lesser extent through transfusions. And one can see here that this cohort has really aged over the years as a cohort. So in the period between 1988 and 1994, the epidemic was concentrated between those in their 30s to 50s. 10 years later, when surveyed, the epidemic had really just phase shifted into the 40s through 60s. As a result, the NHANES survey has suggested that nearly 3 million persons in the U.S. are chronically infected. More recently, however, we have seen perhaps a new spike of cases, and this has been in the very young group of patients, as shown here on the right panel, of patients who have now developed acute and chronic infection as a result of injection drug use. And much of this has been fueled by the opioid epidemic. So we are backsliding at some respect in terms of being able to reduce the frequency of new infections. So serologically speaking, this is the pattern of hepatitis C with progression to chronicity, which is generally speaking the rule, in contrast to adult-acquired hepatitis B. 75 to 80% of the time, patients will move on to chronic infection. The earliest appearance is that of HCV RNA, which can occur as early as 2 weeks after inoculation. This will be followed weeks later by the possible occurrence of symptoms, although in many instances there are minimal or no symptoms with chronic hepatitis C or with acute hepatitis C. This is followed by the appearance of antibody hep C, which does not have neutralizing activity, and we do not have IgM-IgG subclassification. So the anti-HCV will persist indefinitely and does not distinguish those who have cleared successfully from those who have moved on to chronicity. It is HCV RNA that will determine those who have chronic infection. There may or may not be elevations of ALT over time. In fact, many patients will have persistently normal ALT. So ALT cannot be used to distinguish those who have cleared from those who have chronic infection. When we think about the natural history of chronic C, and again, 80% will move on to chronicity with stable or variably progressive rates, we now know that at least 20% of these patients will move on to cirrhosis or end-stage fibrosis, but that number with longer-term follow-up may be as high as 40 to 50%. Among cirrhotics, we can see that there's variably progressive courses. Some may be slowly progressive, but yet at least a quarter will move on to the development of hepatic decompensation, the need for transplantation, and an independent risk for hepatocellular carcinoma, aided and abetted by accelerants like heavy alcohol use or HIV co-infection, which may compress the natural history curve from anywhere from 20 to 25 years on the median to as brief as 10 to 15 years. When we look at the progression of hep C by biopsy, we can see that in contrast to a person who's uninfected, we can see here that in mild chronic hepatitis C, earliest stages of fibrosis tend to occur in the portal tracts on this trichrome stain, and then with a more advancing fibrosis, we start seeing portal-to-portal bridging, so-called bridging fibrosis, and eventually completes the course by forming regenerative nodules in these dense bands, these seas of dense bands of collagen. We have increasingly been able to rely on non-invasive measures of fibrosis in persons with chronic hepatitis C. We have used both serum markers as well as imaging or elastography-based testing. The serum tests are typified by one such as this one, which is called FibroSure, which incorporates these 5 analytes into a weighted score. And one can see here that the performance is best at the extremes between F0 and F4. We can do a reasonable job of excluding those persons with advanced fibrosis, i.e. F4 disease, from those persons with lesser stages of fibrosis. Between F0 and F4, there are large confidence intervals and really far less accuracy in terms of being able to accurately stage a patient with regard to fibrosis stage. The performance, again, in terms of specificity, sensitivity, positive and negative predictive value, again, are highest at the extremes. And it's thought that potentially up to half of biopsies could be avoidable, at least using a serum non-invasive fibrosis test. More recently, there has been the development of a number of forms of imaging-centered means of assessing fibrosis in the form of what we call elastography, or measurement of stiffness of the liver. This is one such example called transient elastography, otherwise known as FibroScan. It is an ultrasound-based technique that sends a shear wave to the interrogated organ, in this case the liver, and the speed of transmission of that wave across the organ is a reflection of the stiffness of that organ, which is thought to be a proxy for fibrosis. This is a continuous variable which can increase further beyond early cirrhosis to later forms of cirrhosis in a quantitative manner, and those higher forms of cirrhosis may in fact be able to predict portal hypertension or even the risk for hepatocellular carcinoma. It's a very easy test and very safe. It takes 5 to 10 minutes to perform at the bedside. Again, the performance characteristics of transient elastography are demonstrated here. Once again, does a very good job of distinguishing those with F4 or cirrhotic disease from those with lesser forms of fibrosis. And this is quite helpful when we're trying to stratify our patients with hepatitis C with regards to cirrhotic versus non-cirrhotic state in terms of planning for subsequent not only treatment, but also screening for portal hypertension and for HCC. When we think about the treatment of hepatitis C, this has been a long and arduous road, which has again been marked by incremental progress using essentially a backbone of interferon, a nonspecific antiviral cytokine, which induces hundreds of genes that have antiviral effect against hepatitis C. One can see here that we have made only, again, incremental progress over the years, starting with standard interferon, followed by the addition of ribavirin, which enhanced sustained response rates fairly impressively, and then with modification of the interferon to a weekly version using pegylation, we're able to get, with combination with ribavirin, upwards of 50+% sustained response rates. This was capable of being done only in those patients, however, who could tolerate and did not have contraindications to interferon. More recently, in the period from 2011 to 2013, with the introduction of the first direct-acting antiviral, we're able to enhance this rate to 75%. But again, this required a backbone of PEG interferon and ribavirin. When we consider the DAA classes, let's go back to the NS3 protease inhibitors, the NS5B polymerase inhibitors, the nuke and the non-nuke varieties, and then the NS5A inhibitors. And what I will want to point out to you is that all of these classes have had increasingly potent versions of each of these classes. However, it should be noted that the nuke polymerase class has a very high barrier to virologic resistance. And this is because the virus does not tolerate mutations at the active site where these nuke polymerase inhibitors act, because those mutations lead to crippled HCV replication. So as such, this is an extremely attractive class of compounds to include in a regimen because of their high barrier to resistance. Furthermore, because they are not handled by the cytochrome P450 system, they are cleared by the kidney, there are minimal drug interaction potential for the nuke class of polymerase inhibitors, in contrast to the other three classes. But that said, these four classes represent an armamentarium for us to potentially imagine combination antiviral therapy for hepatitis C. And I say combination because monotherapy using the very first introduced class of protease inhibitors produced dramatic antiviral effects, to be sure. But when given as monotherapy, unfortunately, at least in two of the dosing groups shown here, given over 14 days, we saw the emergence of resistant variants, which represented actually the selection of variants that had predated the receipt of antiviral therapy. So in other words, there is rapid selection of variants that are pre-existing as a result of the extraordinary viral diversity that are present in a given infected individual. Thus, monotherapy as a strategy, unlike hepatitis B, was clearly a non-starter, and we were going to have to envision a more combination approach, such as that used in the management of HIV. So in this setting, because we now have a multiplicity of classes, we could potentially envision combining a member of one class of therapy with a member of another class of therapy because of their multiple non-overlapping resistance profiles. This way, we could achieve the twin goals of potent viral suppression combined with prevention of emergence of resistant variants, and potentially accomplish the extinction of viral replication for sufficiently long enough period to bring about sustained virologic clearance or cure. So with the introduction of a second class of compounds, we were then able to potentially envision this strategy at work. So the first such example of this was the use of a nucleotide polymerase inhibitor, in the case of sofosbuvir, with ledipasvir, an example of an NS5A inhibitor. So these two classes were given together as a once-a-day regimen for anywhere from 12 to 24 weeks in conjunction either without or in conjunction with ribavirin in genotype 1 infected patients who had never been treated before, 15% of whom had cirrhosis. And you can see here that even as little as 12 weeks of the combination given without ribavirin produced exceptional rates of sustained virologic response, tantamount to virologic cure. This extraordinary result led ultimately to the development of a more pan-genotypic regimen that works on all 6 major genotypes. And the data for sofosbuvir plus this NS5A inhibitor, which is pan-genotypic, is demonstrated here, in which we see, again, extraordinary rates of response across genotypes, shown here, genotypes 1, 2, 4, 5, and 6. Now, it should be noted that genotype 2, that an early therapy for genotype 2 had been sofosbuvir and ribavirin. And this produced high rates of response of about anywhere from 94 to 97%, but was dependent on ribavirin, which can cause dose-dependent hemolytic anemia. So when sofosbuvir and valpatisvir were introduced, they were compared to the standard of care for genotype 2 at the time, sofosbuvir and ribavirin, given for 12 weeks, and produced a statistically significantly improved rate of response, that is to say, 99%. And that was true whether a patient was treatment naive or treatment experienced. So a new standard of care had been established for genotype 2 infection. Genotype 3 had also proven to be difficult to treat with sofosbuvir and ribavirin, with sustained response rates in cirrhotic patients as low as the 60% range. So with the introduction of a pan-genotypic NS5A with sofosbuvir, we were able to describe and evaluate the success of this regimen separately in a phase 3 trial of genotype 3 infected patients. And one can see here that that the success in not just non-cirrhotic patients could be observed for sofosbuvir valpatisvir among both treatment-naive and treatment-experienced patients, but can also be seen among cirrhotic patients, where now over 90% of patients could be successfully treated with an all-oral regimen, which was the first time we had really eclipsed the 90% plateau in this group of patients in a DAA or direct-acting antiviral regimen. More recently, the FDA has approved another pan-genotypic regimen known as glecaprevir, which is a protease inhibitor, and pibrenizvir, an NS5A inhibitor. And this has again been approved for all genotypes. But I wanted to point out to you that for genotype 3, including patients with cirrhosis, shown here on the far right, and even treatment-experienced patients, the administration of anywhere from 12 to 16 weeks of this regimen without ribavirin could again produce exceptional rates of response in this previously difficult to treat group of patients. So now we have regimens that could work among patients with the major genotypes in this country, genotypes 1, 2, and 3, including patients who are treatment experienced and have cirrhosis. What about patients who have been historically extraordinarily difficult to treat? These include patients who could not be given interferon-based regimens, including patients with decompensated cirrhosis for whom interferon actually potentially hastens the decline of liver function. So the availability of all oral therapies was tested in this group of patients as well, both for safety and efficacy. And one can see here that in this prospective study, randomized study, evaluating 12 or 24 weeks of sofosbuvir, ladipasvir, and ribavirin given at a lower dose with escalation is tolerated. In patients with genotype 1 or 4 who had child class B or child class C cirrhosis, one could see here that there were extraordinary rates of response measuring in the mid to upper 80s, whether one got 12 or 24 weeks of therapy. And this was a group of sick patients who had albumin levels between 2.5 and 3 and had significant portal hypertension. So clearly benefit was conferable even to this very sick group of patients. So too did those who had HIV co-infection benefit from this rising tide. In this setting, patients who had HIV co-infection historically had not responded as well and did not tolerate interferon-based regimens. Now, with the availability of sofosbuvir and ladipasvir given for 12 weeks in co-infection, whether treatment naive or treatment experienced, whether cirrhotic or not, we saw across the board exceptional rates of sustained response in this group of, again, previously difficult to treat patients. So now with the availability of DAAs, we've had sufficient experience over the last several years to have very small numbers of patients emerge who had failed combination direct-acting antiviral regimens. So with yet a third class of therapy approved in a combination of sofosbuvir, velpatasvir, and an NS3 protease inhibitor known as voxeloprevir, we now have a triple combination known as sof-vel-vox that can be offered to patients with failure of a DAA-containing regimen, whether an NS3-containing regimen, an NS5A containing regimen, or both. And you can see here again, regardless of genotype, regardless of prior regimen, we see here again extraordinary rates of sustained response for this group of patients who can be salvaged successfully after an unsuccessful course of DAA regimens. So when we think about patients with chronic hepatitis C, we can think about them by genotype and really start thinking about a potentially pan-genotypic approach to patients, again using either glecaprevir, pibrentasvir for anywhere from 8 to 16 weeks, the latter 16 weeks for treatment-experienced cirrhotics, or sofosbuvir velpatasvir given for 12 weeks. There are genotype 1 specific regimens still available, including sofosbuvir ladipasvir, which can be given for 8 to 24 weeks, crisaprevir elbasvir for 12 weeks with an extended duration in persons with high-level resistance. Genotype 2 is a simpler regime that can be, again, treated with GP for 8 to 12 weeks or soft-vel for 12 weeks. For genotype 3, again, GP can be given for 8 to 16 weeks, and sofosbuvir velpatasvir for 12 weeks with the consideration of addition of ribavirin for treatment-experienced cirrhotics. And among DAA-experienced patients, we can envision using sofosbuvir velpatasvir, voxeloprevir for 12 weeks. Ideally, all chronically infected patients should be treated, and for those with advanced fibrosis, it's very important to remember to continue HCC screening because while the risk of ACC is dramatically decreased, it is not eliminated. So screening should continue in these patients. Furthermore, HBV infection status should be assessed in all these patients because of reports of HBV reactivation in dually infected patients that occurred during direct-acting antiviral therapy for Hep C. So a brief word about HCC screening in patients with either chronic hepatitis C or chronic hepatitis B. Twice yearly ultrasounds are the recommendation, with or without serum alpha-fetoprotein testing. For those with abnormal or coarse echo texture, planar imaging with CT or MRI can and should be considered. HBV carriers should be screened for HCC because of their increased risk because of insertional immunogenesis. Men over 40, Asian men over 40 from endemic areas, a woman over 50 should be screened. Africans over the age of 20, because of their high rates of HCC, should also be screened. And anyone with a family history of HCC should also be screened. In those persons over the age of 40 with elevated ALT or HBV DNA over 2,000, these persons should also undergo screening. Screening, again, should continue even after the accomplishment of viral suppression in the case of Hep B or cure in the case of hepatitis C. For instance, interestingly, there were reports of HCC early after a DAA cure of hepatitis C. However, many subsequent studies have suggested that those risks were due to the presence of strong risk factors for the development of HCC in these patients compared to those treated in an earlier era with interferon. This requires further clarification, but again, the mandate to continue screening for those persons with advanced fibrosis and Hep C remains. Finally, a consideration of hepatitis E virus. This is an endemic virus across much of the world, including Latin America and the Indian subcontinent, which has high mortality rates, particularly in pregnant women. In the United States, interestingly enough, there are high seroprevalence rates, as described in the NHANES 3 study, as high as 20%. The natural reservoir appears to be swine through much of the world, including in this country. In this country, acute infections are less frequently described and may be more clinically silent. Indeed, they may account for a sizable portion of unexplained acute rises in liver function tests, again, usually on an asymptomatic basis. It is usually an acute self-limited infection, but as I suggested at the beginning of the talk, may become chronic with prolonged states of immune suppression. And so recipients of organ transplantation, such as liver transplant recipients, may develop chronic hepatitis E virus. The good news is that this may be responsive to a short course of oral ribavirin. Diagnosis of hepatitis E can be secured using hepatitis E virus serology, either IgM, IgG subclass, or nucleic acid testing using HEV RNA, although it should be noted that the methodology and technology still is undergoing optimization. So to summarize, hepatitis A virus is a vaccine-preventable illness that can produce, again, self-limited acute hepatitis and does not move to chronicity. Hepatitis B and hepatitis delta are chronic bloodborne pathogens. Their chronicity is dictated by the age of exposure. Replication is associated with more severe outcomes, and antiviral strategies should therefore be aimed at persons who are identified as having replicative HBV. HDV superinfection or co-infection can occur, and it is superinfection in particular that has a more aggressive natural history. HBV can be effectively suppressed, but generally speaking, not cured. But the good news is that this is associated with excellent clinical outcomes, and HBV, of course, is vaccine preventable. Hep C is much more likely to be clinically silent, as accompanied by high rates of chronicity. But the flip side is that with the development of direct-acting antiviral therapies, it is curable with over 95% rates of success. Hepatitis E virus is a fecal-oral transmitted, again, self-limited acute infection that can become chronic in immunocompromised individuals. So now that we've covered the alphabet of hepatitis A through E, I'd like to ask you a few questions. First question, which of the following is false? Hepatitis B is vaccine preventable. Hepatitis A is vaccine preventable. HCV is curable. Viral load predicts HBV natural history. Viral load predicts HCV natural history. HBV and HCV are risk factors for hepatocellular carcinoma. And HEV should be considered as a cause of hepatitis in the United States. So the correct answer, which is false, is viral load predicts HCV natural history. We know that viral load, as we talked about earlier, is associated with outcomes in hepatitis B virus infection, but there is no such relationship for viral load in hepatitis C infection. So E is the correct answer in this context. In all other instances, HBV and HAV are vaccine preventable, HCV is curable, HBV and HCV are indeed risk factors for HCC, and HEV can cause hepatitis here in the United States, are all correct statements. Which of the following is not a reason for the success of combinations of direct-acting antivirals in achieving sustained virologic response for hepatitis C? A is multiple non-overlapping mechanisms of action of the DAA classes. HCV does not have a stable latent form. HCV must continuously depend on replication for its viability. Or DAAs were always destined to work. The correct answer is D. DAAs were always destined to work. This is not a reason for the success of combinations of DAAs. There are multiple non-overlapping mechanisms was a key point in developing a successful strategy to prevent emergence of resistant variants, which come in high frequency in Hep C. Hep C does not have a stable latent form, which allowed the virus to be stopped in its tracks with a strategy of halting replication and applying a stranglehold correspondingly. And again, Hep C is dependent on replication. So D is the correct answer. Finally, which of the following is false? A, DAAs cannot be safely administered in hepatic decompensation. B, DAAs accomplish comparable rates of success for HIV co-infected persons. C, DAAs can salvage prior failures with DAAs. And DAAs can be successfully given to patients with advanced renal impairment. The false statement, which is correct, is that DAAs cannot safely be administered in hepatic decompensation. We described earlier that regimens can be administered safely to patients with child class B and C. DAAs produce excellent rates of success, comparable rates of success in the HIV co-infection. There are now regimens that can salvage DAA failures, and DAAs can be successfully given to patients with advanced renal impairment, including glecaprevir and pibrentasvir, which are not cleared renally. So I thank you for your attention and point you to these references, which include the web-based AASLD IDSA HCV guidance, which can be accessed hcvguidelines.org, as well as additional references shown here. Thank you again.